Hello, everybody. I'm really excited to be here with y'all. I first wanted to get started. So we're going to be doing a panel on AI and large language models in digital mental health, the potential benefits and harms, ethics, and health equity. And I wanted to introduce the amazing panel that we have. I'll say I'm really excited to hear what they're going to be saying because I have had conversations with some of them on this topic, and the others I definitely follow their work. So we're going to be having Alison Cerezo, a PhD, pronouns they, them, she, her. Alison is a health equity researcher, licensed psychologist in California, and an associate professor of counseling, clinical psychology at UC Santa Barbara. The research has been funded by the National Institute of Health and California Department of Public Health. Alison also serves as the role of head of research and health equity at Empathic.ai, where they bring thought leadership as a health equity researcher and practitioner to develop innovative data methods that demonstrate the potential of ML AI to address health equity at scale. We are also going to be having Chris Hemphill, pronouns they, them. Chris Hemphill focuses on how data science can help us understand and improve the human condition. Hemphill is Director of Commercial Intelligence at Woebot Health, a role that combines healthcare data science and healthcare strategy. Chris's work addressing bias in machine learning algorithms has earned them the honor of being a fellow of NYU McSilver Institute for Poverty Policy and Social Justice Research. This work at the intersection of tech and strategy has a broader theme, working with healthcare leaders to drive ethical and effective decisions with AI and algorithms. Chris also focuses on that intersection in Woebot Health's Meeting of the Minds podcast, which focuses on healthcare leaders in the value, strategy, and behavioral health space. To take a break from all this, Chris loves trail running and creating electronic music. We have three other folks: Hannah Lawrence, PhD, pronouns she, hers. Hannah Lawrence is a clinical psychologist working with Google's health team within the Center of Excellence in the Mental and Behavioral Health. In this role, she partners with teams across Google, YouTube, and Fitbit to develop and drive strategy for tools that improve people's mental health globally. A particular focus of Dr. Lawrence's work has been developing and enacting policies for the use of large language models in the mental health domain. Her work at Google is informed by her background researching adolescent depression, self-harm, and suicide, and developing scalable interventions to reduce risk for these mental health concerns. She co-founded and currently serves on the leadership team of the REACH Youth Advisory Board, and she holds additional appointments at McLean Hospital of Harvard Medical School and Oregon State. We also have Oliver Smith, M.A. Oxon, pronouns he, him. Oliver is the founder and director of Daedalus Futures, a responsible AI consultancy that supports organizations to create strategic advantage by using AI responsibly. He was one of the founding executive team at Koa Health, which span out of the Telefonica Alpha in 2020 with a £50 million Series A, where he was responsible for strategy and ethics. Prior to Koa Health, he was director of strategy and innovation at Guy's and St. Thompson Charity, responsible for investing £100 million over 5 years in the innovation across acute, primary integrated care, biomedical research, and digital health startups. He was a senior civil servant in the UK Department of Health, responsible for UK tobacco control policy and UK obesity policy before that. Oliver was also a policy advisor in the Prime Minister's Strategy Unit under Tony Blair. He has an MA in Politics, Philosophy, and Economics from Oxford University. And last but not least, we have Nicholas Jacobson, PhD, pronouns he, him. Dr. Nick Jacobson is an assistant professor in biomedical data science and psychiatry at Dartmouth's Geisel School of Medicine, directing the AI and mental health, innovation and technology, guided healthcare, AI, AIM High Laboratory, and the Treatment Development and Evaluation Core with the Center of Technology and Behavioral Health. He studies enhancing the assessment and treatment of mental health using technology. This includes using intensive longitudinal and passive sensor data from smartphones and wearable devices and developing scalable, personalized tech-based treatments. Dr. Jacobson focuses on creating just-in-time adaptive interventions with essential quantitative tools. His smartphone apps for mental health, downloaded by over 50,000 users worldwide, support his research. He is also the principal investigator of an R01 from the National Institute of Mental Health, developing deep learning models to monitor depressive disorder symptoms. Additionally, he pioneered Therabot, a generative AI psychotherapy program providing real-time tailored treatment for various mental health disorders. Lastly, I'll introduce myself. My name is Nikiforova. I use they, them pronouns. I'm currently head of clinical and research at Violet, and really excited to be here with all of these amazing folks. So the first thing that I want to say is the intention here is really to be very is really to be very collaborative. We want to get your questions, whether through the Q&A or the chat. I like to keep an eye out, so I'll let the participants know. Please feel free to drop any questions you have for these folks. And I think given the topic that we have, I wanted us to get started on the pros and cons, or the pros and cons / risks of AI/ML in the mental health space. I think this is a time-honored classic question, so I would love to first pass it to Alison.
All right, thank you. Sorry, I was trying to figure out how to get into this space.
All good.
Okay, can you repeat the question, Kay?
Absolutely. I said we have a time-honored question for AI panels, the pros and cons / risks of AI in the mental health space.
Yeah, well, I mean, I think a lot of the focus has been on the cons, which is, it makes a lot of sense, right? Even if we think of like our ethics code as psychologists, it's like do good, do no harm, or like the first two things, right? And so safety is always the thing that we care about, right, as practitioners. So that makes a lot of sense. But I will say I really err on the side of the potential. I'm very, very excited. And so, I've spent probably, I don't even want to say how many years, I know it's over 15, as a health equity researcher. And I've always been somebody who's worked in systems, right? So I used to work for California State University, and then I worked for the chancellor's office, and like understanding how students migrate out of like certain degrees, or like students of color in particular, how they maybe don't, stay or retain in the university. And so I think for myself, I always have like loved the idea of just working with data and understanding what data can tell us, and becoming much more granular in our ability to understand what are barriers or facilitators for people to be able to succeed or thrive in their lives. And I feel like with computing power now, right, we can really do that in some pretty incredible ways. And so for me, I'm somebody who's been a health equity researcher. So I really, really focus on the ways that we can understand root problems of systems to make sure that those folks that are the most vulnerable get the resources that they need. And it's really my firm belief that if you want to create good interventions, you really should focus like with the universal design framework, and make sure that those folks who are the most vulnerable or lack the resources are really centered in the work so that everybody benefits. And I think with AI, that capacity is happening now. And so I'm stepping out of my faculty job, and I'm full-time at Empathic, senior vice president now of research and health equity. And so my goal really is to scale as much as possible the ideas that we know, like, and the truth is that we know a lot of the problems around health equity. We just don't have the tools, the resources, the mechanisms sometimes to solve those problems. And I think now there's the potential to do that in a different kind of way. And so I very purposefully, right, made sure to move into the space the last couple of years. But to do it at this point, because I think now that tech is everywhere, and AI especially, it's already part of our lives, right? Whether we know it or not. It's now's the time, especially if you care about doing it in a way that is equitable, you have to be on the front lines of that. And it also means that you have to have your hands in policy. You have to have your hands, right, working with large healthcare systems to understand how they will uptake. And so I did a fellowship in implementation science at UCSF a few years ago. And that's one thing too, is like, how do we know that there are interventions at work? How do we make sure that those interventions are reaching patients, especially the most vulnerable patients? So I feel like, yes, we should always talk about safety, like privacy, all the things, but I don't want us to be stuck in that space to where it prevents us from actually being able to make most of the moment and really do incredible things that are possible. All right, I'll stop there.
Absolutely. That's a wonderful response. And I think we'll definitely get back to the sort of cons, risks, and different safety assessments necessary. But that, kind of that optimistic view and positive viewpoint of it, I want to know what folks think the first really high impact area for AI would be in mental health, or alternatively, something you're really excited about in the space, like something that you're seeing where you're like, yes, absolutely. So anybody, feel free.
I can happy to jump in there. So we've been working in this space for about 5 years, specifically on generative AI delivering psychotherapy. And the first 6 months when we were designing our system, like I had some really big ideas on, we were going to chase big data on where the data lived. And that led to some models that behaved wildly poorly. I think there's a lot of folks that are just going where a lot of data is early in the space that'll probably learn some of the same lessons we did. That just was not a path that was effective. And one of the things that we've been doing is designing a system really fully generative, but where the data is trained on what we want it to say directly. And so we've got 100,000 human hours invested in creating this. So really heavy involvement from my group. And we just released our first, completed the first randomized controlled trial of that. I just put out a manuscript related to this, and the outcomes are so fantastic, surprising. I mean, like, I was watching that, I read every message for like the first 6 weeks of the trial that was sent to or from the bot. And it was, you know, several tens of thousands of messages. So this was like, they were coming in constantly. It was really keeping me too busy. But I think the thing that was really exciting about this was that I think the engagement was really promising. The outcomes showed differential response in all of our primary target areas: anxiety, depression, eating disorders. And the working alliance was like as good as the norms from outpatient psychotherapy. Folks are spending 6 hours on this thing. I'm so amped up about the potential for this area to really like potentially deliver care that is more dynamic and personalized and real time and scale. I mean, these are all things that are why I got interested in this whole area. So it's really interesting to see like this come out. I think there are major dangers associated with this. We're not going to release this out on the open system, and anytime in the near future. We've got a lot more testing before we do that, but I'm really excited about this area. I think there's a lot of real promise.
May I piggyback on Nicholas?
Love it. Yes, please.
Okay, cool. Because like we talk about the opportunity, we talk about the ability to deliver things at scale and at lower cost, but rightly, there are a lot of concerns about whether or not systems are fair or biased, and a whole host of other issues. But what gives me a tremendous amount of optimism is the question of where were those concerns and how visible were those concerns with all kinds of things in the past, such as the way that clinical trials have frequently been set up that exclude Black patients or people in other classes for drugs. We're talking all the way back to like we're talking about decades of research, but now we finally have well, not finally, I don't want to discredit the work of people that have been trying to shine a focus on this for years, but this is a mainstream conversation, a mainstream topic. People know that term, responsible AI, and I think that it establishes a potential for a crossroads here, where people can develop systems that go on and perpetuate bias and perpetuate the issue, but it's now so known and now so pivotal and important for healthcare decision makers that I'm hoping that conversations like this empower decision makers, be they statistically minded and have that background or not, but still to be able to ask the important questions about diversity of data sets, teams, and the people that are building and working on these approaches.
Yeah, I think it's so interesting how that's changed in the last couple of years, and to see this be front and center for conversations, especially when we think about the risks and the cons. So I think we'll have a little bit of time. We'll have some time to get to that in terms of how to build with health equity in mind from the ground up, because I think that that's also something important to go into. But Ollie, I also wanted to get your thoughts on something that you're either really excited about or what you think is going to be the first big, achievement in mental health in this regard.
Thank you. Happy to build on those responses as well. I'm really looking forward to getting to the stage where we're starting to rethink the model of care that we have now, because I think quite rightly we start from, well, what do we do now, and how could we maybe use AI or in many cases a chatbot to say, well, there are not enough therapists, so we can use AI to kind of actually scale the number of therapists we have. But I'm really excited to get to a stage where we started thinking, well, actually, maybe we could create a kind of team of different AI mental health professionals that kind of surround a person. And what would that look like? And how could that be quite different? And maybe we'd have a chatbot that would be more, I suppose, well-being and kind of everyday focused, then we might have one that would be kind of focused on a particular specialty. And they would obviously talk to each other. There would be a team and they would kind of wrap around that individual. And also thinking much more about how that team or teams might support people both individually and in the kind of the context of the relationships that they're in as well. So I'm really excited about some of the things that we're only really just starting to kind of scratch the surface of, because of course we've got to get at that baseline of, but does it even work in the model that we're familiar with? But that's where I'm really looking forward to seeing it go into that kind of future space. I was trying to see if any of the current chatbot companies are doing that yet. I can't see that, not the mental health ones anyway, people like Woebot and Wise, I can't see that they're doing that yet. They're probably doing it in R&D and it's just not kind of publicly available. And someone must be looking at this.
And noticing that a lot of digital mental health companies are also moving towards team care. It'd be so interesting to see that,
Exactly.
mirrored specifically within this.
Precisely.
So, all right, I'm very excited about your responses. And I wanted to go
one more sort of like different idea here.
Oh yeah, please, of course.
Awesome. I'm thrilled to hear so much about scaling some of these ideas, obviously coming from the Google angle. And one thing we're really excited about is getting good evidence-based information about mental health out into people's hands, whether that's what treatment works best for what people, or how do I even connect with a therapist. People are already turning to these large language models to ask questions about mental health. And so I think that's another role that AI can be playing to support people's mental health globally. And then another piece is also scaling the training in mental health interventions. We often think about chatbots as being these direct service providers. We've done some work at google.org and training the folks who are answering crisis calls using AI to support how they actually triage those calls and then respond to folks who are at risk. And so also thinking about ways that humans can be looped into these models to make sure that people are actually accessing care and that we can scale this training to have more mental health providers available to people.
Can I add to that, Kate?
Yeah, please.
Okay, Hannah, I'd love hearing that. That makes me so excited. I know for us at Empathic, like some of the work is also specifically in supporting like coaching providers. And so some of that is like health coaches, right? Volunteers on a crisis text line, but it also is like surgeons, and other use cases in healthcare settings, because empathy is literally like accurate understanding. Like that's what it means, right? When you really break it down granularly. And so that like the importance of like empathic, communications, and that's comprised of many, many things, right? But just being able to ensure that like, if you can have accurate understanding between providers or between a provider and a patient, right? Like the ways that then turns into like improved health outcomes. And so, but needing to do that in a way that is also representative of diverse lived experiences, right? Like we say that oftentimes, like maybe for like communities of color, right? But like, even if it's like, it means something really specific to be like a person of color in a particular region of the US and even more, right? But I think that like, that makes me so excited to imagine like how we could do that kind of work moving forward.
Yeah, thank you so much for bringing the training element into it. I think that I don't hear it as often. And I was recently having a conversation with the director of clinical training for our clinical psychology program. And one of the things that they were most interested in was how do we do better training, in part because a lot of the methods are so, according to them, so outdated. I wouldn't disagree. And so I think that that has quite a lot of possibility, especially within the clinical space. I'm going to jump to a question. Actually, we have one in the Q&A, so I'd love to get some thoughts. So we have, given the landscape of the US healthcare system, it is siloed and lacks data sharing / interoperability. With these challenges, how are you building AI models that are inclusive and representative of the entire data sets? So I think it's just really speaking to that element where there's, different, very fractured healthcare data.
I really, I was trying to figure out a way to respond to Ollie after it had gone through a couple of cycles. And I think this is the opportunity here when we're talking
Great.
about lack of sharing, interoperability. And honestly, that's not necessarily a barrier that is 100% technological. It's more of a political barrier and decision barrier in terms of how organizations are structured to share with each other. But we see overall that there's context to be gained by these systems working with each other, and perhaps perhaps the intervention that one app may recommend would vary based on something that happened within a different part of that system. So for part one of that question around interoperability, one thing that gives me hope is these frameworks like precision behavioral health that are coming online, where rather than a one app to rule them all approach, or a like the opposite side of that, the opposite side of the universal platform is a whole network and often mess of applications where often digital leaders are leading baskets of hundreds of applications, and they don't necessarily know when they fit into the clinical journey. So it does give me hope that, hey, if there's a unified framework, it can start pointing people in the right direction to the intervention that's most needed. In addition to that, so there was the other part of the question that addressed the challenges in building models that are inclusive and representative of entire data sets. Now, very often, it can be extremely difficult to obtain a representative data set, but it like at times, like, unfortunately, because the data that one has collected represents the economic conditions and the social conditions that led to people seeking care and led to those data elements being captured and people's trust within the healthcare system. So at the very least, even if an equitable data set can't be acquired, at the very least is to understand what those limitations are and how to work within those limitations, to measure outputs, and like if we can't be completely successful on the input side, then it's a call on leaders and data science teams to look at what the outputs are and identify like equitable approaches there. I feel like I've hogged the mic a bit too much. I want to open it up for others, but just wanted to get my 2 cents there.
I have 2 ideas on this because I feel like it's literally my job. And so what is that? I don't know what that is. So don't do a piece or don't say 2 things. Okay, right after I just did it again. Okay, so the one though is that like I really focus on data partnerships as much as I can. And partly because when you look at like general data sets, right? One is that metadata is really hard to come by. So like you can't even test for AI bias sometimes. But the second piece is that research shows that like, you know, that like communities of color, LGBT communities face incredible amounts of like, you know, discrimination, stigma from their providers. So if you're training AI models on just general data sets of therapy or medical sessions, they're going to be entrenched with bias. And so we have to be super careful about that. So my focus is really like data partnerships where you have expert clinicians who like know how to deliver Afrocentric approaches to care, or know how to like really work around trans, LGBT affirming types of therapy or medical, you know, support. I think that is super key. But then I think also it's like you have to have these like partnerships. You have to develop trust with healthcare systems. And oftentimes it's understanding like what is their pain point, and then helping to deliver a product that helps to solve that pain point to some degree. And so with that, it's also helping, you know, like different systems understand the kinds of metadata that are going to be critical to be able to get some of the you know, analysis that we need to know, like how their interventions or systems are working better for some people versus others.
I'll also just add, in addition to having data that is high quality, making sure that the people who are evaluating our models and testing them and giving feedback on responses also represent the people that we're hoping to help with those models. So making sure that clinicians at various levels of training, for example, from different backgrounds, that individuals with lived experience with mental health concerns are also the ones that are helping us train our models and saying this response doesn't fit my experience, or this response doesn't characterize my mental health concern in a way that I think is good or equitable or the right way to do things. So also thinking about sort of the training testing piece of this and making sure we have diverse perspectives there.
I quickly want to agree with that, just because there can be there can be scenarios where if you have cultural sensitivities but you're not in the room while a decision's being made, then it gets completely ignored and they don't even know that they've created a problem.
I just want to build on some of those comments as well by saying that sometimes it's really easy to just only look at the technology in isolation, and I think what it's certainly implied by a lot of what kind of co-panelists are saying is you need to look at it as as a whole. You need to look at the AI within the context of the entire care pathway and think about what is the care that you are delivering for whom, by whom. And in some ways, the limitation of the data is like you are where you are with that data. So kind of look at your entire care pathway. What could you do with what you have? And kind of start there and use that as building a foundation. And then maybe you're able to generate more data over time because you're going to be able to deliver some kind of care value to the people that you're serving. Because too often I see people like, unless I can solve it all at once, I can't do anything at all. I said, no, don't think like that, because you have to look at the whole pathway.
I think just building on that thought, I think there are so many different ways that AI and digital mental health more broadly can be integrated. And I love that people are going into the care system. That's fantastic. But I think that the care system is also a huge barrier if you were to align just the care system and all of your work within the care system, because many folks operate outside of the care system. And so we do a lot that's direct to patient facing outside of a care system, in large part because of the access there. So I think there are so many paths and so many successful paths. So just because we're doing it doesn't mean it's the right way. And I think all of the operation within the care system is fantastic, not to knock any of it. I think there's a lot of room for it. But I do think outside of the care system, there's a lot of promise as well.
The one last thing I would say is that like Aim Ahead is a really nice resource. For the life of me, I don't know what that acronym means, but it does mean something big, because that's 8 letters. But the point being is that they also just came out with a new call for it's like community collaborations in developing AI systems. And so it's not a huge amount of money, but it's something, right? And so the ability to maybe like pay for people sessions or to whatever, work with a community organization to develop AI systems. But I think that part is super critical. It's often like we have the tech and maybe we have more computing power now, so everybody's just wanting to build tools, but they're not necessarily doing it in partnership. And so anytime I review a grant, it's not just like, can you do the thing, but can you sustain that thing, right? Like, I don't want it to be a pop-up thing that then goes away in a year. And so, really investing in those collaborations and partnerships is now what Aim Ahead is doing. And that's an NIH funded community. And it's also really intended to be a community for underrepresented scientists to be able to take up space in the AI world.
Yeah, and specifically on this topic, in terms of just replicating the existing exclusion within the healthcare system and also existing exclusion to developing different care models, I think it's very heartening to see moving in this direction of so many folks being involved and also really focusing on the health equity piece around this. And I did want to go back around a little bit to the risk mitigation element, because we had a lot of really great answers of things we're excited about. And at the same time, I think some folks want to hear your thoughts on that. But yeah, really, what do you see as the potential risk areas? One of the things that was mentioned is like somebody disclosing SI to a chatbot. So if anybody wants to jump in, I don't know, Hannah, if you had any particular thoughts.
Sure. I mean, I hate to spin this back into a positive again, but I do think that there are enormous opportunities there to connect someone with appropriate resources. And so if the one place that someone feels comfortable disclosing SI is to a chatbot or some other AI tool, and we can then use that as an opportunity to connect them to crisis resources, location-specific resources, to give them ways to start a conversation with a loved one or the healthcare provider to seek more support in those moments. I also think that there are great opportunities there to respond to those risks in a way where we can reach more people. On the flip side, I also think we should understand where the limits of AI are and where human providers should step in, and in what moments we should be directing people kindly, empathetically away from AI and towards people who are around them, whether that's family members, loved ones, other clinicians.
I mean, the one thing I would say is that like humans are actually not great at diagnosing or even being able to ask some of the questions around risk ourselves. And this is not like me just saying that, like I am licensed, right? And but I think of like, honestly, one of the most attractive things to me for AI was that I had like founded a clinic and it was really difficult to supervise everyone. I could not watch every minute of therapy, it was impossible. And so the idea that like, you know, could a transcript like tell me, right? Like, is someone actually assessing risk when there are elements of risk, like obviously present in a session, right? Because it is oftentimes the case that like people will shy away from asking about suicide or homicide, right? Because it's just kind of our natural inclination to do that, even if we are licensed providers. But research shows again and again that like we're not the greatest, like we're not consistent or reliable in our diagnosis anyway. And so I think in some ways, like AI might actually be really helpful, but it's as a co-pilot. Like you don't get rid of the human as much as it's a co-pilot to support providers or volunteers or people on a crisis hotline to make sure that they really are paying attention to risk in ways that are critical.
Yeah, and one of the questions that came in, which was answered, was really talking about how, you know, how the panelists viewed human therapists right now being able to label themselves experts with either conditions or cultural groups, and also overestimating their abilities. So I think that that's not something I hear about as often, but I think it's something that's really important around this. So any other risk mitigation? Anybody else want to jump in?
Yeah, well, one thing that really concerns me is that you know, in my community, I was raised up like my mom was very adverse to me like filling out race on the applications and putting out data that might be used against me. Which is, I mean, that's unfortunate because I know that on the other side, there are people that are looking to identify the right resources for people and build helpful systems and things like that. But on the other side, there are people that are not. And one thing that really concerns me is if we adopt these systems and collect information, and then it's sold to entities like Facebook, for example, or used in a way that violates trust. I've heard the quote a bunch of times. The first time I heard it was from Anish Chopra, who's the first CTO of the United States. And he said that innovation can only move at the speed of trust. So if we're taking actions that violate that trust and like that can basically undermine the whole scale of progress that we're looking for here.
One final thing I would say is that when we think about risk is that like there are things like SOC 2, you know, GDPR, like there are all these other things that like you do have to have in place. And so it's not sort of the Wild West or not, I don't know that you necessarily always have to have them in place, but oftentimes customers are not going to work with you. Healthcare systems are not going to work with you if you don't have some of these security measures in place. And so just, you know, reminding people that like, people have been working in AI for a minute. And so it's not as though, right, that we don't have some sense of that. Could we do more? Could we have more policy, right? Like coming out of the White House or whatnot, like absolutely. But it isn't necessarily the Wild West. Yeah. For social media, maybe that's different.
One risk I'd add is there's kind of a risk about risk, which is particularly for chatbots or conversational agents or whatever you want to call them, the kind of anthropomorphization that we have means that we can often view what it's saying as being more sophisticated and viewing the agent as being more sophisticated than it actually is. And I've heard people say, well, I don't know why it did this, so I'm gonna ask it, why did it do this thing? No, it doesn't work like that. It doesn't it can't kind of look into itself and tell you kind of why it did it. It's just kind of, this is the likely next token, and it's just kind of constructing a kind of really convincing sounding sentence. Okay, maybe you could say if it's kind of retrieval augmented generation, there's, you know, it could say kind of these are the sources that I looked at, but it still can't tell you why did I summarize those sources like this. So, and I think that kind of sort of screws with our heads a little bit when we're trying to understand these things, because it's so good at kind of sounding like a kind of a conversational human that I think we sort of think it's more sophisticated than it is. It's kind of, I think there's this kind of worry of a risk about us being able to actually perceive the risks.
And I think one that calls on a powerful question of how that agent communicates and makes itself known what it is and what its limitations are. Notice I didn't even apply a gender to the agent. Working at Woebot, I've noticed a lot of people gender Woebot, which is interesting to me. But overall, I think that folks who are there's no incentive to winning the Turing test here. There's nothing to be gained from fooling people, especially when I think that the question of serious questions came up earlier. It always does. It always should. But you want to be ready to identify hey, there's an escalation path. I'm just a robot. I've only been designed to address these types of issues. And it goes all the way back to that trust concern that I have. We fumble the bag on something like that, and people then just put everything in the same category.
It raises an interesting question about ethics more broadly. If we think of mental health providers or psychologists or whatever domain having to follow an ethics code, do we expect that AI systems who are operating to achieve similar tasks should follow the same ethics code, a different ethics code? Informed consent, for example, what do people know about the risks and benefits of AI systems before they engage with them? What does it really mean to be informed? Do we have enough information to fully inform people about the ways in which interacting with AI will impact them in the short or long terms? I think they're really good questions about, what sort of code of ethics we should be following here more broadly.
Ultimately, I think a
Yeah.
lot of the concerns surrounding ethics and risks and harms are mostly ultimately empirical questions. These are questions that can be tested. These are questions that can be studied. They're ultimately how beneficial or harmful they are. And I think honestly, I think that related to informed consent, I mean, that can be studied as well, but in terms of perceptions and how to educate folks, this is a really early space. And I think this is going to take a long time to get everything sorted out. But I think the nice piece of this is ultimately, this is all something that can be studied and operationalized and broken down. And I think that's really promising. I think one of the unique things about it is they can mimic the flexibility, I think, of what humans can provide, but they can be systematically improved and systematically studied with the data that goes in and out of them. And so I think that's one of the real opportunities of this space that's really exciting to me, is that these systems are as bad as they'll ever get. They're only going to get better from here. So in that way, I think there's a lot of promise. And even when they aren't perfect, they say exhibiting problematic behaviors that can be shaped.
I'm going to have to say it. I think listening to this, it is really heartening to see you folks working on these questions, especially in the, I think nuanced way that we're talking about this. There's one question that I wanted to ask from the Q&A. So there's a common internet tech product idiom to trace users' cohorts cases back to incentives rather than demographics in regards to assessing behavior with a particular product or service. And so specifically with health equity and AI LLM, how do the two relate in resulting in excellent outcomes like recovery potential? So work, living independently, symptom reduction, and reducing negative outcomes like suicidality. So it's just that balance of both of those two.
There's a lot to that one, right? There's multiple components, but I think that there's a thread which is around incentives. Like when we think about what Netflix is incented to do, their algorithm is designed to to identify the content that's going to keep you watching the longest. But in working within a healthcare context, especially with the delivery model that a lot of these digital mental health organizations have, I think it really falls on them to understand the needs of the patient populations they serve, and how that can be served through the health plans, health systems, et cetera, that they work with. Because within healthcare, within the framework we're working with, we have things like value-based care and other incentive structures that are designed rather than encouraging a huge amount of consumption of movies. We're talking about like incentives to keep people healthy and keep them away from having to have highly acute, high cost scenarios. So I think it's I think it's critical for founders, leaders within technology, to do things like read the White House's playbook on social determinants of health, to understand the types of incentives, incentive structure that that the country and other entities are overall looking to build to drive and maintain health outcomes. It's one of those kind of rare scenarios where like I have conversations about the fact that, oh wow, people are looking at addressing housing, people are looking at addressing all these other issues that they hadn't before, and it's because we need to start taking a look at the new incentives that are being made to address care upstream. I hope that, does that get the spirit of the question? I hope.
I think so.
I'm going to spin off of that, Chris, because you mentioned like this engagement, like an optimization of other digital products. And really, a lot of them are optimized for engagement. And related to AI and large language models, a lot of products in this space that have been developed are really optimized for engagement, even for the ones that are specifically mental health adjacent. I haven't seen mental health products that have been designed directly for this, but I've been a little behind the scenes on some of the companies that are out there that are in the very adjacent space to mental health, interacting around problems related to things like loneliness, and probably seeing a lot of mental health populations as part of their use space. And a lot of them are trying to keep folks on, and that's the way that they're trying to optimize their outcomes. That's their reinforcement learning mechanisms that they're trying to apply to their models, is what message will keep someone on the platform chatting. And that's, I have a real concern about that, particularly in these adaptive systems. I think that has a real potential to really amplify and isolate folks. So I think it's really important that folks that are, when we're designing our systems, we design it for the right outcomes and keep that from the outset. So I think just really keeping that in mind within this space. And you know, I think regulation, because of this, is like, those kinds of products are the things that get me most amped up in this space about regulation, because I really do think that could be harmful. So I am concerned about kind of how fast the space is growing and some of the ways it could be used.
Wonderful. I think there's going to be an engagement AMA, user engagement AMA, shortly after this. So not AI ML related, but they will be talking about digital health. So definitely stick around for that. And I think, you know, as we're kind of coming up on the last 5 minutes, I wanted to ask. There's a question from the Q&A. What should mental health providers do to prepare for the future of AI-based MH work? Because I think that with a lot of direct care providers I've been talking to, this is kind of their like fear, but also interest and also trepidation. So does anybody have any thoughts specifically on how folks can prepare or how folks can at least get up to speed?
Now, I'm not a mental health provider myself, but one thing that I think is important is to understand. I think there was conversation around where these things fit within the clinical journey, and I think it's important to identify other clinicians who may be deploying these types of solutions and engaging with their patients, and you know, catching up between sessions and things like that. I really think rather than this one app to rule them all approach, there should be just an understanding of, hey, where these fit in the clinical journey and how to how and when to distribute to patients, what kinds of discussion topics to help drive the effect of the application. Because there have been studies that show that there's a certain amount of gain within some digital mental health apps, certain gain in person, but there's a potential adjunctive impact that can be earned there.
I would say anecdotally, a couple of things. Like I just taught my last class, and so literally using ChatGPT, the free version, to show folks like, hey, you have a vignette of somebody who needs a resume but hasn't written one in 15 years, and like feeding it and then getting a real like easy template, right? And people being like, I can't believe that like I just did that in like 10 seconds, you know? But like being able to understand like even just like real basic use cases. And then I think another piece is that all providers struggle with burnout, right? Because like the kind of paperwork we have to submit to get reimbursement is wild. And so I think being able to support people like to use AI in ways that just like benefit them and allow them to focus more time on patients is going to be really critical. And then I think you just, incrementally, you increase that in some ways. But I think for a lot of providers or just, other faculty that I'm connected to are also psychologists, licensed psychologists. It's like seeing me do it, and I'm like critical of everything, is like helpful. But I think also being able to say like, it can help you do this thing, or we can use this tool that does that thing. And so, yeah, but I think burnout is a huge one. And so like just helping providers to do their jobs is going to be really critical.
I think one thing just in trying to educate folks that are really interested in the space and maybe dabbling is to also just be aware that a lot of the implementations of the primary frontier models, unless you have partnerships with them, are not HIPAA compliant. And so like just the dabbling piece, I think trying to optimize notes or things like that, yes, they're good at it, but just make sure that the product that you're engaging with, anything that's sensitive, is really something that you already have an agreement with an organization surrounding. There are a lot of ways to get those agreements and secure that, but and some products that are designed to be HIPAA compliant. So I think just make sure that you don't put that into some of these large frontier models. One of the other things I think somebody put in the chat also related to the fears, and I think you had mentioned that I tried to answer this in the chat, but I think it's really, I really try to hammer this whenever I talk about this, because folks get their, like this prickly sense when it comes to AI and these things raised, where it's like, oh my gosh, they're trying to replace me. And that's not the goal. I mean, the recession rate for mental health during the recession, mental health providers have like less than 1% unemployment. The ratio of like common mental health disorders with patients with those disorders to providers of any kind is like 1,500 to 1. There is too much of a market right now. And if AI can do a smidgen of closing and addressing some of that, awesome, or making people more efficient. But the human providers will always be part of the care system. Nobody's trying to take I think, providers out of the system. So really important, I think, and AI won't replace you. The market's frankly just too big.
I would echo that point. The other thing I would add on what you could do to prepare is certainly with generative AI, it's much more accessible than if we're having a conversation about electronic healthcare system, healthcare records, sorry. So try it out, not in your practice, but kind of just like in your personal life, play around with it, change the temperature or on the Gen AI and kind of see what happens. And you can get a feel for how would I think about using this in my practice? How easily does it break or not? And I think it's, in that sense, it's much easier to get a sense of what is it I'm buying? What are the kind of questions I should be asking when I'm kind of thinking, when someone's telling me you need to integrate this awesome product that I want to sell you.
Okay, and I think we are at time. So what I'll say is thank you so much for this conversation. You can watch it afterwards. And just from this conversation alone, I think I did feel some optimism, some positivity, including for mental health providers, and just this idea of building in an ethical way with health equity at the front. So thank you all for sharing all these things. It was really wonderful to have you here.